That's why you have a tie on.
Do you think this is for you?
Yeah, I mean,
Why do you have a tie on?
We had the accreditation meeting today, and so we wanted to appear as if we were giving due respect to the commissioners. We don't.
so I can't just blurt out anything randomly.
Good evening, everyone. Welcome. I'm very happy to welcome Dr. Troy Heidish here today. He has been in the trenches long enough to know what it really means to care for patients, unlike me. But more importantly, he is the CEO of a company called Smart House Calls. It's a telemedicine company that he started 3 years ago now. And we started working together, looking at what could we potentially do about 2.5 years ago, and since then have become good friends. So he's got great insights into how to make technology work for important clinical purposes. I'm very excited that he found the time to come and speak to us.
Thank you. Thank you, Dr. Misha. I guess, kind of before I talk it, I understand that there's somewhat of a mix. We've got some people who have been involved in healthcare before, and others who are planning, obviously, if you're in this program, doing that side. Those that were in healthcare or are in healthcare, what have you done? What's your focus? Where have you been?
I work at a billing company.
Okay.
I'm a nurse.
Nurse and ICU, floor nurse, ER.
Floor nurse.
Floor nurse.
Surgical.
Okay.
Business operations.
Okay. Anyone else? Well, my history is I started out. I love to tell people this, and hopefully you'll get a laugh too. I started out, in healthcare really at the age of 18, and I like to say that I started there. I was a groundskeeper for a hospital. So, and ever since that time, I've always seemed to be affiliated with hospital or healthcare of some sort. I did that. I was an impressive, I think, kind of student because it only took me 5 years to get my first associate's degree. Later on, finished up my bachelor's and my master's at Bernal University in Gainesville, and then completed my doctoral work in 2009 at the Medical College of Georgia, which then became something else, and has now become Georgia Regents University, and we're all trying to keep up, all the alumni are trying to keep up with that particular thing. But a lot of the idea behind a telemedicine company, and how many of you have thought about or heard about telemedicine? Most of you? Well, the idea for me ultimately came out of my experience being a nurse practitioner, working in both family medicine and ER medicine. And I saw that problem, and I don't know how many of you, and maybe I'll start off with this, sort of asking this question, how many of you have ever gone to your doctor and wondered, why the heck did I spend an hour sitting in this waiting room for him to talk to me or her to talk to me for about 10 minutes and then usher me out with a prescription? Okay, so at least half of you. And how many of you have ever had a family member or you've ever done this where, hey, you actually need to talk with the physician or the nurse practitioner or PA, and you call up the office and you never get to talk with them. You're shuttled around between receptionists, medical assistants, techs, office managers, and it seems like they do anything they can to prevent you from getting to the physician. Well, ultimately, that's kind of where that sort of was born out of in what I saw. Essentially, the way we work in a medical practice, because we're having, we don't have much for, our reimbursements are low, we're constantly under the gun, the reimbursements keep shrinking, overhead continues to increase, and so we're shuttling through 30 to 40 patients a day at times. So we're spending 5 or 10 minutes, tops, ourselves, intensely in the room on average. Now, of course, some patients will spend a half an hour, 45 minutes, and other people get 2 minutes. And it can be that bad. So the thought of 30 phone calls coming in a day and people wanting to kind of stop in the middle of what you're doing to talk with them becomes an impossible feat. And then on top of that, a telephone call is free. We can't charge for it. So what we do instead is we tell the secretary, no, tell them to come in, I need to see them for that. And it's maybe not something we need to see you for. We could certainly take care of you over the phone. but we know A, we don't have time, and B, we can't get paid for it, so bring him in, and then you get to sit there, fight traffic, take time off work, sit in a waiting room full of 6 strangers that are coughing all around you, or maybe talking to themselves or talking down in the room as you wait for us. And, you know, that came, and my vision for Smart House Calls started in that particular atmosphere, understanding that, you know, this really sucks for patients. And this really sucks for providers because, you know, we'd like to spend more time with patients if we could, and we'd like to be more convenient, but there's no way to really do that effectively. And then I got to thinking, well, what if we replaced some of these telephone calls and some of these in-office follow-ups? What if we use telemedicine and just connected to patients right there in their own homes? You know, what would happen? How could that possibly change that sort of dynamic? And so that's why I didn't develop myself. I went out and found the guys who were smarter than me to help me develop the software. And I essentially just sort of led the team saying, this is what we need, no, we don't need that. And we started building it. Now we've got family practice physicians, psychiatrists, psychologists, therapists, cardiologists around the country using the software in a couple of different ways. One is to connect to their own, you know, to connect that person at home. But they're also, because the system works so well, they're connecting to tertiary care centers, they're connecting to rural health centers, they're connecting to other specialists, and effectively taking care of patients where they are, taking care of patients where it's the most convenient, and really doing it in a very dynamic way. And I like to say that really what telemedicine should be about, or what it is about, is let's stop moving people and let's start moving data. Let's make everything more efficient. So I've spoken a little bit about some of my frustrations, but some of the, obviously this is going to be hard to see, sorry. We've got some problems in healthcare. We have declining physicians per capita, and that is for a couple of reasons. One reason is that physicians are fundamentally changing. The younger ones, as they come out of medical school, they don't want to work 60, 70 hours a week anymore. They don't want to be on call the rest of the time. They don't want to be at the hospital every weekend. You know, they want that life-work balance. And so we have these baby boomer physicians who are getting close to retirement, who grew up in that model that, well, you know, it's just what we do. We work 60, 70 hours a week. We're a doctor. It's important. That's what I chose to do. And now we're moving to fewer physicians who are graduating as family practice physicians, and they want to work less. And then we've got half of the population that we have physicians marrying physicians and having children, and it doesn't always work to have 2 full-time people working a physician schedule and taking care of your family. So invariably, the man or the woman slides down a little bit to take care of that responsibility. So we're in that sort of stage where we've got all these baby boomers coming into the marketplace. We've got millennials now who we're finding are very acutely aware of what their health is like, and they want to take those proactive steps. And it's funny, the millennials are actually only about 2 million shy of the baby boomers as far as numbers. And they want to use almost as many healthcare resources as the baby boomers do. And we have not nearly enough people to take care of that. As I spoke, you know, Medicare reimbursements are decreasing because of the sequester. There's several places here where physicians now are making 2, 3, 4% less than they were prior to this sequestration, and that's causing much angst within the community, and you know, particularly family medicine, because that's always been the lowest reimbursed physician out there, is that family practice doctor. Let's see. You'll have to forgive me. I'm going to skip through some of this so I don't talk too long. I don't want to bore you in this nice warm environment. But you know, as we find out, we've got this huge volume of patients, and we have only so many physicians. We only have so many nurse practitioners. When we're talking about sort of that physician shortage, we're also talking really about nurse practitioner shortages and PAs. They can't keep up. The volume that go through those programs cannot keep up with where the demand is, so we've got an overall shortage. But as physicians, as nurse practitioners and PAs start seeing patients, and they have to see them more regularly, or not more regularly, excuse me, more quickly, there's only one, or they have to see more of them, there's only one or two ways you can go. Either you extend your hours to fit in everyone, or you see them in much shorter blocks of time. And that's generally where it seems like medicine has focused in on it, and what's been driving the fundamentals is that they're trying to rush through and see as many people as fast as they possibly can. And then as a result, they understand that, I know I'm not spending as much time with this person, so to supplement that and make sure I'm not screwing up, let's go to a CT scan, let's get lab work, let's go ahead and get an ultrasound, and costs start to skyrocket. So, long waits, impersonal service, and rapidly increasing costs. I think that speaks probably perfectly to that. The other thing that we find is that chronic diseases, and this is a problem more for employers, large employers that have physician workforces. They have a problem with two sorts of problems in healthcare. Chronic diseases can cause what's called absenteeism, obviously. You get sick, your blood pressure jumps up, you have a heart attack, you have to go to the hospital and you're out of work for a number of days, or if not entirely. But the other thing that's somewhat more insidious is presenteeism. And what that is, or presenteeism, and that is you go to work, but you don't feel well, and you don't work as efficiently as you did before, you're not nearly as productive, and it actually, the numbers show that presenteeism is a far greater drain on industry than absenteeism is. So, what's the solution? And my thought, I love the idea of, and really why I came to telemedicine as a potential solution, is that we can make healthcare more convenient. We can do it in such a way where physicians can charge for all of the services that they provide. Employers can benefit from telemedicine as they have employees who are sick, and rather than having to wait or take time off work to go to a physician, they can have telemedicine suites set up within their walls. And if you have a cold, if your family has a cold, if you need a refill on your blood pressure medicine, you simply can walk into a suite and get things taken care of. It's kind of like taking that sort of take care model, the Walgreens pharmacy sort of model, the retail clinic sort of model, and let's put it in an even more convenient spot. Let's put it where they work. The reason I say less is so much more. Typically what we see with telemedicine companies is that you have this great big cart. It usually stands about 5-6 feet tall. It's got 2 monitors. It's got a full Windows machine attached to it, and it's got a number of peripherals. And this thing costs $50,000 to $120,000 per unit. On top of that, you then buy a video codec that you download onto that server or download onto that hard drive, and then wherever you connect to has another codec. Now those typically can cost between $5,000 and $50,000 a pop. And I looked at that and thought, how does this make sense anywhere? And really the only place that it has made sense thus far is for government grants, tertiary care centers connecting to specialty sort of telemedicine clinics around the nation. And Georgia is a fantastic example of that. We've got a wonderful organization out there called Georgia Partnership for Telehealth. They've raised grant money. They've essentially set up, I can't remember if it's 200 sites now around the state of Georgia, where subspecialists in Atlanta can connect rurally from, they can go from down to South Georgia, a cardiologist can see a patient down in South Georgia and for 15-20 minutes, and then 20 minutes later they're seeing someone 200 miles away and providing the same sort of care, but great, but really expensive. So our thought with Smart House Calls is, why don't we take that codec and let's put it on a server in a secure sort of facility, a tier 1 facility, and make it such, and when you do that, essentially all the complexity goes away. The carts and those sorts of things can still cost money, but we can also piecemeal those together at a much lower cost. And let's get it everywhere. Let's let that cardiologist that's sitting at Emory connect with 5,000 doctors from around the state. As long as they've got a computer and a web camera, they can affect consults, they can affect change, and they can help those patients where they are. And that's really what we mean is less is so much more. Let's do something that makes a lot of sense. It's very simple, simplified, almost a disruptive innovation, and that way we can branch out everywhere. I'm going to skip this. Some of the other thoughts behind telemedicine, ACOs, primarily, we're based out of Athens, Georgia. There are one of the two of the first ACOs in the country, have started there, and they're ramping up right now, but they are going to be using telemedicine as far as their clinical coordinators. When they have someone who's being discharged from the hospital, they'll send a clinical coordinator there to meet them, make sure they get set up with all their appointments. They'll send them home. A home health nurse will take a laptop with, and be able to connect to Smart House Calls if they get there and say, you know what, this doesn't look quite right. Let me call Dr. Bond and let's show him what's going on, and I'm going to take a blood pressure, and we're going to go through this whole thing. We're going to make sure. And that effectively, what that does, that escalation piece, allows that patient to be treated earlier, first of all, and it's less likely that a physician who has no way of knowing what's going on with that patient other than a nurse telling them, feels much more comfortable saying, no, we're okay, let's change the medicine a little bit, feet look okay, there's not too much swelling, I looked at the lab work, everything looks okay, let's just send you back out there tomorrow and let's follow up. When they're on the phone, our automatic thought is like, I don't want to get sued, I can't see that patient, send them to the ER. And we go back there, drives up costs, ACOs fail, so that's why they're so interested in telemedicine technology.